this webinar provided by osseonews.com. The topic for today is optimal implant selection and positioning, and we will be talking also about the vertical and horizontal dimensions of implant restorative space. I'm Dr. Louie Al-Faraje, founder of California Implant Institute, and would like again to thank Osteo News for the invitation to provide this webinar to its members. All right, so I'm the author of Surgical Complications in Oral Implantology and Oral Implantology Surgical Procedure Checklists. Both books are by Quintessence. My third book, Surgical and Radiologic Anatomy for Oral Implantology, will be released in a few days, early October 2013. All right, we're located here in San Diego, California. This is the location of California Implant Institute, and we provide different courses for implant dentistry, ranging from a 20-day fellowship program to a live patient hands-on program in Rosarito, Mexico, to a cadaver hands-on program also in our location in San Diego. All right, so we're going to start with the vertical and restorative occlusion spaces, if you will, for implant dentistry. So when you are treatment planning a case, obviously it would be nice to know what kind of prosthesis the patient will end up with as you are planning the location, the size, the diameter, and the number of the implants. So it's very important to perfectly have an idea, and the patient also should know also the kind of prosthesis he will be ending up with when the implants will be restored down the road, anywhere from 2 months to 6, 7 months, etc. All right, so in order for him not to end up with a prosthesis that he did not sign up for, and accordingly, we would like to know the minimum vertical and horizontal spaces needed for certain prosthesis. So I subdivided this topic into 3 scenarios, as you can see here on this slide: fixed single restoration, multi-unit, full arch, fixed restoration, and then removable implant restorations. We will start with the fixed single restoration. As you know, we have cement retained or screw retained prosthesis, and then each of these 2 prostheses could be ceramic or porcelain, occlusal or metal occlusal. So we have 4 different fixed single implant fixed prostheses, and we're going to start with the ceramic fixed cement retained. This is probably the most popular, if you will, implant restoration. I put together this table, and you can see here on the left-hand side, we have 9 millimeter, which is the minimum required for the cement retained porcelain crown, and then 8 millimeter for cement retained metal occlusal crown, 6 millimeter for screw retained porcelain crown, and 5 millimeter for screw retained metal occlusal crown. So it would be nice to remember these numbers, but would be even nicer if you know where these numbers came from. So if you look here at this illustration, we never place implants below the bone level. Accordingly, I place the implants either flush with bone or slightly above bone. That will depend on the location in the mouth, aesthetic versus non-aesthetic zone, and then the thickness of the soft tissue. So let's say that the implant is ½ millimeter above bone, and then we need implant platform to the margin of the crown, or the abutment, if you will, another ½ millimeter. Then I decided that, from general dentistry, I borrowed that number. We need a minimum 5 millimeter of abutment height in order for that crown not to keep coming off. So that's already 6. We need ½ millimeter for coping, and then we need ½ millimeter for cement, and then a minimum of 2 millimeter of porcelain, and that's how we came up with the number 9, as you can see here on the left-hand side in this table, the left column. All right, so 9 millimeter, and then obviously for the metal occlusal, we do not need the 2 millimeter of ceramic occlusal. 1.5 millimeter would do, and there is no need also for the thickness for the ceramic or the metal core, and thus we have 1 millimeter less. It's important to mention that implant vertical space, restorative space, what we mean by that is the distance from bone, not from the soft tissue. So clinically, obviously you see where the soft tissue is, but for this, or for the lab technician, for this purpose here, is the distance from bone to the opposing dentition or to the occlusal level of the future prosthesis if we don't have you know, an opposing dentition for our planned restoration. All right, so 9865, and if that should be clearly, obviously understood, and you should know these numbers as you are sitting and treatment planning for the case. You know, after you collect the diagnostic data from the patients, from diagnostic wax-up to diagnostic casts, CT scan, health history, photos. Once you have all these data, now you're sitting and you're treatment planning a case. One of the things you need to be looking at, you know, there's too many things obviously to look for as we're doing treatment plan, from the, you know, from general health to certain habits, to bone density, to the biotype of the patient's gum. One of the 20 things, again, you'll be looking for is the vertical and horizontal restorative spaces, making sure you can offer the patient the prosthesis that he obviously would be candidate for. Otherwise, let's say the patient has only 6 millimeters and you're treatment planning for him a cement retained porcelain crown. Obviously, the lab will be calling you and telling you that you know, with that much space, it's impossible for me to do this kind of prosthesis that you prescribed. Accordingly, now it's too late. The implant in place and also integrated, and the patient will not be able to get the crown that he thought he's getting, and that potential, obviously, a problem. Now, for multi-unit full arch fixed restoration, the minimum numbers are the same. So it doesn't matter really if it is a single restoration or multi-unit. When it comes to the minimum numbers, the ones we just talked about here, the 9865, they are the same and they do apply to the multi-unit. However, we have here a magic number, and you can see here, which is the 15 millimeter that I put in yellow, under which, if it is multi-unit case, fixed, then we do the prosthesis from porcelain material. Otherwise, if it is you know, over 15, then the prosthesis should be fabricated from acrylic. Porcelain will fracture if it is a little bit too thick. Acrylic all the way around. Acrylic does gain strength from bulk. So the thicker the acrylic, the stronger it is. However, when it comes to porcelain, you would like the prosthesis to look nice and have transparency and as much anatomy as possible. However, if it exceeds, you know, 2.5, 3 millimeters, now becomes very brittle and very easy to fracture the porcelain of that prosthesis. So removable prosthesis now, usually a bar overdenture or locator or ball overdenture. So the number here is 17 millimeter. Where that 17 millimeter came from is 3 millimeter bone to soft tissue. Roughly, you need minimum 1 millimeter from the level of the soft tissue to the inferior border of the bar for hygiene purposes. Otherwise, as you know, it's you know, straightforward malpractice if the patient cannot clean around his prosthesis. And then we have 5 millimeter bar height, especially if it is a cast bar, minimum 5 millimeter. And then from literature, I found the number 8 millimeter which is the minimum acceptable for the thickness of the acrylic. So again, 3 plus 1 plus 5 plus 8, that come to 17 millimeters. And again, it's a very important number. You see, if the patient lost his teeth long time ago, chances you have that much and more. But let's say a patient came and he wants a bar over denture and he is about to lose his teeth due to failed endo all over, fracture roots, trauma, whatever, and he did not yet lose any alveolar bony height. In that case, obviously he will not be candidate for bar over denture. And if you place the implants for bar over denture, it would be very challenging, if not impossible to fabricate. You will have to convert them to another prosthesis like locator over denture because it requires less of a vertical restorative space. You see, but if you know this number, then obviously you would be easily able to do alveoloplasty on the day of the implant placement just before you place the implants. And now when you place the implants, you will have the minimum required for bar over denture or even a little more. You see all those numbers we mentioned so far, 9, 8, 6, 5, 15, and now 17, all those are the minimum numbers for the mentioned prosthesis. Would be nice always to have 1, 2, if not more, millimeters on the top of those minimum. But with these minimum numbers, the lab will definitely be able to fabricate for you those prostheses that we mentioned. The last one I would like to talk about is the removable prosthesis, but that would not be a bar, but a locator or ball attachment. For that, 3 millimeter bone to soft tissue, and then only 2.5 to 3.5 abutment height instead of 5 millimeter for the cast. We do not have here the 1 millimeter for hygiene required under the bar, and then 8 millimeter or more is the again the thickness for the acrylic. So as you can see here, 14 millimeters or could be a little bit less for locator abutments in particular of vertical restorative space, and that would be adequate for you and for the lab to fabricate for the patient a ball or again locator over denture. So as you can see here, these numbers again are 9, 8, 6, 5 for single fixed implant prosthesis, 15 for multi-unit, under which we said we should do porcelain, above which we will do acrylic, 17 for bar over denture, and 14 for locator or ball over denture. Now with the 17 number, I would like to revisit that number again for the 17, which is the bar over denture prosthesis. That can be down to 15, if you will, by fabricating for the patient a CAD-CAM milled bar instead of the cast bar. So for that one, would be 3 millimeter would be adequate. So we can, even with the 15 millimeter, get away with the bar over denture as long as the bar is milled, titanium bar, for example. That would be more biocompatible, more precise fit, lighter, more pure metal, and on the top of all of the above, when it comes to vertical restorative space, we have only 15 would be adequate for that type of prosthesis. So very important again to go over these numbers. When you have too much bone, that's obviously a very good, very easy problem to handle. You simply do alveoloplasty just before you place the implants. But when we don't have adequate, adequate height, when we have too much, restorative space, vertical restorative space, then you would have to do a bone grafting procedure either simultaneously, or when it comes to vertical bone gain, obviously you have a better chance by doing this as a first stage before implant placement. So it would be blood grafting, GBR, or interpositional grafting, destruction osteogenesis. All those techniques are available to us in to use to gain, if you will, vertical restorative space before implant placement. Otherwise, alveoloplasty if we have too much bone. All right, now that was the topic. for the restorative space. Now we will move to the second topic, is the proper implant placement. Of course, you can always take impressions, send them to the lab, and the lab will do for you diagnostic wax-up. And from that diagnostic wax-up, you can obviously order a lab-fabricated surgical guide, or you can do computer. You can do computer treatment planning, virtual planning, if you will, and then order computer-generated surgical guide or surgical stent. However, sometimes even those are done, there's a mistake, done when fabricating those. Accordingly, the numbers and the guidelines we're going to talk about in the next 30 minutes or so, you would have to definitely know in order for you to be able to do surgery when the guide was not possible to order, or was delayed in the mail, or the lab technician did not do a good job. You will need to be able to verify that, yes, using that stent, even if you have it, using that stent, I will end up with the proper implant positionings and angulations and depth in that matter. So there is a 5 guidelines that you need to follow, meaning the mesial-distal implant positioning, mesial-distal angulation, buccal-lingual implant positioning, buccal-lingual angulation, and then how deep I should be placing the implant. So let's start with the first out of these 5, if you will, areas that we'll be covering. The mesial-distal implant placement. How far I should be placing the implants from each other's or from natural tooth? Or what is the minimum distance also between natural teeth where I should be, where I can place an implant and end up with, acceptable looking, if you will, implant prosthesis. We'll start with the topic here, the distance between implants. So forget about the teeth for now. Let's say you are placing 2 implants or more. What is the distance between your pilot holes, the pilot drills that you're gonna be using to form the osteotomy? And the rule is radius of implant number 1 plus 3 plus the radius of the implant number 2, as you can see here in the upper illustration. So if you would ask me how far my implant should be placed from each other's, I cannot answer that question unless you would tell me what is the diameter of these 2 implants. So now you tell me I'm planning 2 implants and both of them are 5 millimeter diameter, for example, then 2.5 plus 2.5 plus 3, the radius of first implant plus the radius of the second implant plus 3, and that would end up we will end up with 8 millimeter. So now when you drill for your first implant, and as you know, the pilot hole is the center of the implant, because from this point on, with the rest of the drills, you are making the osteotomy bigger, slowly but surely in all direction. Bottom line, that initial pilot hole is the center of the implant that will be placed in few minutes. All right, so the distance, you would have to go 8 millimeter to end up with 3 millimeter distance. So that's very important to follow. Why 3 millimeters? We'll talk about that in a minute, but this is very important, not to have less, not to have more. I would rather have, of course, 3.5 than 2.5, but as much as possible, you need to try very hard to end up with 3 millimeter edge to edge between implants. There is one exception, as you can see in the lower illustration now. Central in. All right, so now let's talk about the first topic, which is distance between 2 implants, or between implants if you are placing, more than 2. So if you ask me what is the distance between 2 implants, I would not be able to answer unless you tell me what is the diameter of the planned implants. So if you're placing 2 implants, and let's say the diameter is 5 millimeter for both implants, so then the distance between your 2 pilot holes, which are the center of your implants, would be the radius of the first implant plus the radius of the second implant plus 3. because we would like to end up edge to edge with 3 millimeter between implants. So would be 8 millimeter in this case. 2.5 plus 2.5 plus 3 would be 8 millimeter. The distance between the two implants replacing the missing maxillary central incisors can be as low as 3, but could be up to 4.5, and that would be normal. So because the bony papillae in this location can be quite big. So 3 to 4.5. Other than that, it's absolutely 3 in every other location. I would rather have it, of course, 3.5 than 2.5. But it's important to try very hard to be exactly 3 millimeter edge to edge when you are placing implants. Again, that distance between two implants and not implant to natural teeth. We will talk about why 3 in a minute here. So why 3? Because we have something called biologic width, and depends on how deep the location of the implant's platform to the crystal bone, and what kind of biotype, thick or thin, and what kind of implant connection, a standard one or a platform switch. So there's a few factors, I named 3, that will dictate if you will have biologic width or not and how big it is. But in general, in average, you have some bone loss, minimal, due to biologic width. Of course, you can have a big amount of bone loss due to infection, due to trauma, due to many other reasons. But the one in particular that is due to biologic width is usually, minimal. Now, that bone loss is vertical. I think in this illustration I did overkill, but just for the point to come across. Bottom line, you have some vertical bone loss, but it is vertical when it comes to due to biologic width. However, even if you have a vertical, it will have some horizontal component. And that horizontal component, according to literature, is anywhere between 1.2 to 1.5, but mainly around 1. So when the implants are placed with 3 millimeter edge to edge, even if you lose some bone, again, due to biologic width reestablishment after the trauma, which is the implant placement in this case, then we will end up still with some bone that will support the soft tissue papillae. See, the soft tissue is sitting on bone, we have bone loss, the soft tissue would follow, and accordingly we would like to end up with a little bit of bone between the implants, so we will prevent the black triangle from happening. What I just talked about, the radius of implant number 1 plus radius of implant number 2 plus 3, that would apply only to crown and bridge type prosthesis. If you are placing implants and the goal is to restore them with bar overdenture, with locator overdenture, or with CAD-CAM high water, Procera implant to bridge type prosthesis, then the rule I just talked about, it's not important whatsoever. In that case, there is other things on my mind. If I have fully edentulous ridge, for example, and I'm placing 4, 5, 6, 7 implants to end up with prosthesis, again, like bar or locator or even fixed but high water type, then I would like to place as many implants as possible, number 1. Number 2, I would like to place one implant as distal as possible to eliminate possibility of cantilever and for the denture not to rock, even if it's implant and soft tissue supported prosthesis. And I would like to equally space the implants as much as possible to equally distribute the forces of occlusion onto all these implants. So again, as many implants as possible, up to 7, 8 or so, and then one as distal as possible on each side, and as equally spaced the implant as possible. The last thing on my mind is the 3 millimeter edge to edge, because that is not important. We're not trying to have a papillae between implants when we're doing bar or high water or locator overdenture. So again, that rule, R1 plus R2 plus 3, would apply to those cases where we are planning to do a crown and bridge type implant fixed prosthesis. Another choice here is width of tooth number 1 divided by 2 plus width of tooth number 2 divided by 2. That's another way of calculating the distance between the centers of two implants. And the third way is 7 to 8, 8 to 9, as you can see here in this illustration. If you look at the distances only between implants, you will see 7 to 8 or 8 to 9. That will depend, obviously, on the diameter of the implants. Now, you might think that these distances are a little bit too small. They are not. These are the correct numbers that you need to follow in order to end up with no black triangle or not too close of implants to each other. So these are the correct numbers, and you will see that if you follow these numbers, you will end up extremely close to ideal, even without surgical guide or diagnostic WhatsApp. We would like to have diagnostic WhatsApp as much as possible every time. It's a plus to have a surgical guide no matter how much experience you have, but there will be, for sure, plenty of cases where you do not have the diagnostic WhatsApp or the surgical guide, and with these numbers you will end up with extremely close to ideal positioning without the help of the guide again. All right, so now distance between implant and natural tooth, that would be choice number 1, width of replaced tooth divided by 2. So for example, let's say you are planning a tooth, let's say number 14 is gone, number 15 and 16 also are gone. The most distal on the upper left hand side of the patient you have is tooth number 13, and you are planning implant for number 14. And the width of that implant mesial-distal is 10 millimeters. Then obviously you would like the implant to be right in the center of that occlusal surface. Accordingly, you will be drilling 5 millimeters from the tooth next door. Another way of calculating that is the radius of the implant you are planning to place plus 1.5 to 2. So no less than 1.5 if by all means possible, and no more than 2. So if the implant is 4 millimeters, I would go no more than 4 millimeters from the where the tooth meets the bone. So from that cementum point to the center of my implant would be 2. No more, plus again the radius of the implant would be 4 millimeters. You might think again that this distance is very small. This is the correct distance, and that's what you should do in order for you to end up with a proper looking implant fixed prosthesis. How come we invaded that 3 millimeter that we just talked about? We said edge to edge between 2 implants. If you are planning to place implant, prosthesis should be absolutely no less than 3 millimeters, but here we said no problem, you can do 1.5 to 2. That's because you will not have biologic width bone loss onto the tooth due to the fact that the implant was placed next door. So the implant would not be affected. Accordingly, the papilla will not be affected if you stay only 1.5 to 2 and not much further. Accordingly, you should be lower, less than 2 millimeters away from the tooth. And again, 1 is okay, 1.5 would be better, but definitely no more than 2, plus the radius of the implant, and that's where you start drilling to place implant next door to natural root. Of course, you need to take the root angulation in consideration. So on the CT scan evaluation, you will need to make sure that there is no tilt of the, if the root is not tilted next door. Otherwise, that will mandate that you will go a little bit further from the root, and if you go too far, you will end up with improper looking prosthesis biomechanically and aesthetically. So you might need to uplift that root or remove that root. If it is too tilted, it will have most likely poor prognosis. So either by ortho or removal of that tooth, you need to do something. Otherwise, the implant prosthesis would not last because it would be biomechanically and not to mention aesthetically is not sound prosthesis. Here is a case where you can see the patient lost teeth number 28, 29, and 30, and I don't have a guide to help me. However, I know these numbers that I just told you about. In this case, I opened flap. Obviously, the mesial and the distal implants are the most important because they are next door to roots, to natural roots, and I cannot move those roots. So I would go 2 millimeters plus the radius of the implant. I drill for the first implant. You go a couple of millimeters plus the radius of the distal implant, and you drill for that. And now you look at the X-ray, and you will see you will also calculate with gastrovial caliper, and you would go from the first to the distal hole. And obviously, if that distance around 16 millimeters, if you remember, we said 7 to 8, 8 to 9. So on average, if that distance is 16 millimeters, I can get away with third implant. Otherwise, the patient will be getting an implant supported bridge. So look here. After the mesial-distal implants, I calculated and I figured I can place implant right in between and still ending up with a good 3 millimeter. Took X-ray, continue with the drilling. You can see on the lower left-hand side picture, I have roughly 2 millimeters, and then the red, and then the first osteotomy, and then 3 millimeter, second osteotomy, 3 millimeter, third osteotomy, and then again a couple of millimeters. And you can see here the implants are positioned extremely close to ideal. I mean, looking here, you might say, okay, well, this osteotomy should be half millimeter to the right or so. But bottom line, you can see here the implant positioning is very acceptable. I was able to make decision on should I place 2 or 3 implants, also going out of these numbers that we mentioned. And this way you will not end up with the implants too far or too close or extra, too many implants for that space. So now it's too tight to restore, etc. So knowing these numbers, again, you will end up with very close to ideal positioning without any help that quite often might not be able to have. Now, distance in between natural teeth, that's very easy because we said we would like to stay 1.5 to 2 millimeter away from natural tooth. So obviously 1.5 millimeter, let's say minimum on each side, plus the diameter of the implant. So what is the minimum distance between 2 teeth I need to place 4 millimeter implant? That would be 1.5 plus 4, the entire diameter, plus 1.5 on the other side. So I would need at least 7 millimeters distance between 2 natural teeth in order for me to place 4 millimeter implant, and for the restoration of that implant to look, nice, for the papillae also to look natural and all that stuff. So that's very easy question. Now you can push that and be as close as 1 millimeter to the root next door, but we're talking about ideal positioning, and again 1.5 millimeter on each side of the implant plus its diameter. This is a case where I did not have that minimum. If you can look here, you can, this patient been through ortho already. Tucking him into ortho again is not possible. And we have just under 6. And we are short of millimeter or even more to place the implant. In that case, what you need to do, either ortho or in this case was not possible, then you would have to compromise and gain more distance by using a narrow platform implant. So this is, we will take I would numb the patient, take football-shaped diamond, and as you can see here, literally one pass, and I would create 2 soft tissue papillae. If there is any bone in my way, it will be also removed. And you can see here, within a few seconds, I end up with a scalloped gum with 2 papillae. I end up with more papillae on the distal. That's because how I started. If you look at the first photo on the left-hand side, you can see there is more gum, obviously, on the distal. But nonetheless, here we go. So one drill, 2.0 drill, and you take X-ray, verify that you are right in the middle between, in the. It's not important really to be in the middle between 2 roots. You need to be dead center on the clinical edentulous area. So the implant crown or the implant should be dead center between crowns and not roots, because sometimes the roots are tilted and you are closer to one root than another. That is not important. As long as you are not too close to a root, hopefully you have a good full millimeter between the implant and any of the roots. But what you look at is to be in between the 2 crowns on the top, because that's where the patient is biting. He's not biting on his roots, and the occlusal forces would be obviously in the middle of that edentulous area. Anyway, so back to our topic here. We 2.0 drill, X-ray, and then place the implant. This happened to be a DO implant system, just like the case before. And we take impression. This is 3 millimeter diameter implant, and we have roughly 4 millimeter on each side of the implant. We had to compromise the 1.5 and restore it with a Procera. The lab here should have removed a little bit more porcelain here as for this soft tissue to relax. That was, I told that to the referring dentist, so to have a better looking soft tissue, but very acceptable. And in order to end up with this results, we had obviously to compromise the diameter of the implant. Mesial-distal angulation now. As you know, natural teeth are perpendicular to the curve of SPE. The curve of SPE is that line, if you're looking from the lateral onto the patient, that line passing through the occlusal surfaces when the teeth are in contact is curve of SPE, and natural teeth are perpendicular on curve of SPE. And I would say do not try to mimic nature here. When you are placing implant, you should try to place it, fairly straight as much as possible. However, just for you to know, obviously, in the case of nature, we have the apices of posterior teeth are tilted toward the distal because they need to be perpendicular to the curve of SPE as teeth come together. So again, in case of implant dentistry, we will try to place the implant as straight as possible. Now, we're not machines, so the implants would not be perfectly straight every time. So what is how much tilt is acceptable? 15 degrees. So up to 15 degrees it's acceptable because you're not machine again, and sometimes the implant slightly crooked, and that is more than okay. Up to 15 degrees. As the implants start to approach 25 degrees of tilt, that's a little bit too much. Over 15 would be pushing it. I mean, 15 degrees in my opinion is plenty crooked, and it's still considered okay biomechanically and all that stuff. However, as you are exceeding 15 degrees slowly but surely, you need to start thinking about removing that implant, and there is no problem with that. You're not happy with the implant, despite your best effort, the implant slightly tilted, you remove it and you put the bone graft and you reattempt to place the implant 3-4 months down the road. It's not the end of the world. It's not malpractice to abort when you're not happy, because that's the you're acting for with the best interest of the patients in mind. Now, having said that, we should try to place the implant as straight as possible. Up to 15 degrees of tilt is okay. Otherwise, remove the implant before it also integrates and becomes really a problem to remove it. The patient lost time. He's twice as mad. There is exception though for this scenario. If we have a multi-unit case and we have very good reason, then it's okay to tilt the implant mesial-distally, not buccal-lingually, up to 30 degrees. Not 15, not 20, not 25. You're welcome to put the implant crooked with 30 degrees, just like all-on-4 technique. But there is a couple of conditions here. You need to have very good reason for that. And number two, which is more important, is it would have to be a multi-unit case. Placing single implant with more than 15 degrees of tilt is not acceptable, because that implant alone is taking the entire forces of occlusion applied onto it during chewing. Now, if you look at the picture on the left-hand side, for example, this implant is roughly 30 degrees tilted. However, by doing so, number one, the patient was able to avoid sinus lifting through lateral window in order to place implant here. The patient might not be able medically to go for that procedure. Number two, these two teeth, number 30 and 31 in this scenario, will not extrude because they have opposing dentition now. Number four, the patient was able to get 2 more crowns on that implant prosthesis without any cantilever. So 3 big reasons, I think one of them is enough. However, all those 3 reasons combined, not good enough if that was a single implant. But being part of 3 implant prosthesis, now that when the patient is biting, he will be biting along the superstructure as a whole at once. So even if he bites on number 2 or 3, the 2 mesial implants will be participating in counteracting the forces of occlusion applied onto that one implant. So they will be forming, we like it or not, some kind of tripod, and the other 2 legs will be helping that leg. The illustration on the right-hand side, it's also the same. By doing that by adding that distal implant, although it's tilted quite a bit, maybe 20, 25 degrees here, we were able to give the patient one more tooth, preventing 30 and 31 from extruding and avoiding sinus surgery. But again, would have to be a multi-unit case, and now that when the patient is biting, he's biting onto all those 3 implants at once, he likes it or not. So to conclude this very topic, as long as the position of the implant head is unaltered, a limited inclination of the implant itself has minor influence on the load transfer to the implant. All right, so now the third topic out of 5 is buccal-lingual placement. Where do I place my implant? I open flap, and do I place my implant in the middle of the ridge, or toward the buccal, or toward the lingual? Well, this topic can be subdivided into anterior placement and posterior placement. Anterior placement, the center of the implants should be under the incisal edge of the future prosthesis if it is cement retained. So for screw retained, the center of the implant would have to be under the cingulum of the future prosthesis. So you're placing implant for number 8 or number 9 or number 10 or number 7, canine to canine, upper or lower. So now you start to drill. The question is, if you're drilling right in the middle of the socket, you're going to end up with positioning that is candidate only for cement retained implant prosthesis, because obviously would not be a good idea to have the access to the abutment, the screw hole access at the incisal edge of the prosthesis. That would be even funny. All right, so by doing the implant in this positioning, you would have to restore it with cement retained prosthesis. All the way around, when you would like to restore the implant in the anterior with screw retained, your hand should be tilted slightly toward the palate, and you will end up with the positioning like the silver implant here with the green line, because we don't care about having abutment that is high so the cement will be able to retain that crown onto the abutment, because this is screw retained. As you know, the abutment and the crown are made from one piece, and you will screw both of them onto the implant accordingly. That's okay for the implant to be very short, and we need to have the access away from the aesthetic zone. So this is the guidelines for placing implants buccal-lingually in the anterior, either under the incisal edge or under the cingulum, depends if we are planning to restore that implant with cement retained or screw retained prosthesis. In the posterior, however, it does not matter if you are placing screw retained or cement retained. The center of the implant should be under the central fossa of the future prosthesis. And this is important to understand. So let's say you opened, let's say a patient came to you and he already lost some bone. You see, if he did not lose any bone, the extraction was recent, let's say for number 14 implant. As you know, the buccal cusp does overlap the buccal cusp of the lower teeth. So now, if the patient came and he has recent extraction, you will be placing the implant in the middle of the alveolar bone, and you will end up with ideal occlusion. If the patient lost already some bone, he lost the tooth a year ago, did not do anything about it, then obviously the ridge will be, already resorbed a little bit. And the implant positioning will be compromised, because you have to put it in the middle of the alveolar bone anyway, unless you are doing bone grafting. But let's say we are not, and we are following where the bone is. Now it's okay as long as compromised positioning is okay, as long as you will compromise the occlusion also, and you will end up with prosthesis that is edge to edge. Now the patient, let's say, lost even more bone, and he did not come until 3-4 years after the tooth loss. Now he has more resorption on the buccal, and the positioning of the implant buccal-lingually even more compromised toward the palate. That is again okay, as long as you compromise the occlusion accordingly, and you will do a crossbite. So if the patient wants ideal occlusion in the posterior, and he lost already alveolar bony width, then you will have to do bone augmentation to bring that dimension of the ridge to the original, if you will, dimensions and place the implant in the middle buccal-lingually and end up with the ideal occlusion. Otherwise, you will have to either do edge to edge or do all the way cross-bite. The patient needs to know what he's going to end up with before, and that is possible through the diagnostic workup. But bottom line, if we have compromised ridge, we would have to also do a compromised occlusion, because no matter what, we need to make sure the patient is biting along the long axis of the implant. The fourth question we have is buccal-lingual angulation. Natural teeth are perpendicular to the curve of Wilson. As you can see here, this green line that is passing through the buccal and lingual cusps on both sides, and teeth are tilted to be perpendicular to the curve of Wilson. So the apices of those teeth, we said they are tilted distally to be perpendicular to the curve of Spee, and they are tilted also buccally slightly in order to be perpendicular to the curve of Wilson. In case of our in our case, the implant placement, you should also try to place the implant, as we said earlier, as straight as possible. I understand you will not end up with the perpendicular to the curve of Wilson, but I'm afraid if you try to be tilted, then you might be tilted a bit too much, and buccal-lingual tilt plus if it is single, that might be a big problem. So you're going to place the implant also as straight as possible. You're probably going to tilt, you're going to go curve, perpendicular to the curve of Wilson anyway when you are doing posterior mandibular implants, because in most cases you have some kind of submandibular fossa that you would like to avoid, and you have to do slight tilt, not too much, just slight tilt and maybe shorter slightly implants to avoid that fossa if it is too prominent. But again, the advice here is to go as straight as possible, but keep in mind that natural teeth are perpendicular to the curve of Wilson. So slight tilt would be better, because the implant would be perfectly lined with the chewing forces path, as you can see here in the red line on the right and on the left hand side of this illustration. Now the last question is how deep should I place my implant? Should I have my implant flush with bone, or millimeter above bone, or 2 millimeters above bone? This implant I placed probably millimeter to 2 deeper than ideal. And the results you can see here on the right hand side, the bone above the implant would be resorbing, and you will end up with soft tissue. Soft tissue would follow, and you'll end up with soft tissue also recession. It won't get any worse, because that was not due to infection. That obviously will keep going until you do something about it, but still that's not something you would like to have. This implant was all the way around placed a little bit too shallow, and you can see also aesthetically not acceptable. You can see part of the abutment, through the gum, etc. We do not want to place the implant too deep. We do not want to place it too shallow. So what is the ideal implant placement? There is too many factors that affect the decision on how deep the implant should be placed. I came together with I put together 9 factors that will affect that decision. But it's very hard to come up with a classification where you have 9 variables in one classification. So the most 3 variables, I think, is the crystal bone morphology, soft tissue quality, in particular the biotype, thin versus thick, and then the buccal-lingual positioning of the implant. So I have here a classification on how deep to place the implant. The class number 1, straight alveolar crystal bone, and that's divided into non-aesthetic and aesthetic zone. So you open the flap, and you really have 3 choices. Choice number 1, you have flat bone, or you have irregular bone, or you have scallop bone because it's anterior extraction. So that's what that was the classification is all about. So now choice number 1 is I open a flap and I have a flat bone. So that could be non-aesthetic zone or aesthetic zone. In non-aesthetic zone, you do not have to do anything about it. You place the implant simply anywhere from quarter to 1 full millimeter above bone level. That will depend on the thickness of the soft tissue, because you need to end up with a good 2 full millimeter coverage, non-aesthetic zone. Now, if I am in the aesthetic zone, like you can see here, I pulled few teeth. I have flat bone, and I take a football-shaped diamond. I scallop the bone, place the implant, and with the scissors, you can see I cut this triangle here, and now end up with soft tissue papillae supported by bony papillae in the anterior. So this illustration will summarize class 1. You have flat bone, non-aesthetic zone, you do not do anything about it. You put the implants in a way that you ensure you have still good 2 millimeters above the platform of the implant. If you are in aesthetic zone, you scallop the bone gently, and then not too much, and then place the implant also in a way that you will end up with no less than 2 to 3 millimeters of soft tissue coverage above the implant's platform. Class 2 now, irregular alveolar crystal bone. You have irregular now, but instead of aesthetic, non-aesthetic, single or multi-unit. In case of single, we place the implant flush with the highest bony level. So the bone is irregular, it is single. We do not want to flatten the bone because that would lose more bone. We might end up with the pockets next door. So in this case, you will place the implant flush with the highest bony level. In case of multi-unit, you either flatten the whole thing and you go by class 1A, or you would be scalloping the whole thing and go by class 1B guidelines, as you can see here in this case. This will summarize class 2. You have a regular bone, single unit, place the implant flush with the highest bony level. Multi-unit, you either flatten the whole thing and you might be doing only bar over denture, you don't care about bony papillae and all that stuff, or you will be scalloping the whole thing and placing the implant in the guidelines mentioned in class 1B in order to have a bony and soft tissue papillae, as you can see here on the lower right-hand side illustration. The third class is the scallop bone. So after you remove the tooth, you might have absolutely no scalloping, extremely minimal. You place the implant flush with bone, as you can see in this case. To end up with 3 millimeters. Or I invented here a medium biotype only for the sake of the classification, where the bony biotype is not thin and not thick, but in between. In that case, the implant platform would be 1 millimeter above the highest bony level, and that will end up with I will end up in this case with 3 millimeters of soft tissue. And the third one is very thin biotype. You can see here how thin the soft tissue is. You can almost see through, and you can see how scalloped the bone is. In this case, you have 3 choices. Either you do scalloped implants, or you do one-piece implant, or you will be the proper. All right, and class 3 of this classification, again, is class 3C, is you have a thin biotype. You can see in this clinical case, the gum is very thin. You really do not need to see the patient to know if he or she has a thick or thin biotype. Looking at the photo would be adequate. That is why, by the way, very important for you to take photos when you are treatment planning an implant case, because after the patient leaves the office, a day or two after that, for sure you don't know anymore. You don't remember if he or she had a thick or thin biotype. Accordingly, you have a photograph like this one here, and you can always revisit those photos as you are doing treatment planning, and you will see what kind of biotype he or she has. All right, so in this case we have severely scalloped crystal bone with thin soft tissue. This is thin biotype, and this is problem in implant dentistry. Luckily, only 10 to 15% of patients have thin biotype. It is problem in the anterior zone for us, when we are doing implants in this area. So for 85 to 90% of patients, that's not an issue, but in these 10 to 15%, it is problem. What can you do about thin biotype if you are doing immediate placement? Choice number one is to do scallop implants. A little bit too challenging, especially for novice dentists. I'm not sure if they are around. I placed maybe a couple of hundred of these implants. I'm not sure if they are around, but they work for me just fine. A little bit too pricey, a little bit technique sensitive. But you can see here the that big bony papillae on the left-hand side is supported by those two implants. At the same time, in the mid buccal, you can see how the implant is going up quite a bit, running away from the oral cavity. So this is one solution. The other solution for thin biotype is to place one-piece implant, because one thing about the thin biotype, it's very unpredictable from the after surgery, how the bone and the soft tissue will react is unpredictable. But in this case, if we have one-piece implant, this happened to be Noble Direct, then if you have more recession than you would like to, no problem. You will take a burr and you will prep that implant. In this case, the abutment and the body of the implant are made from one piece of titanium. You will be prepping that, and you will put that abutment or margin, I'm sorry, for the implant crown a bit higher, and of course, a couple of months after implant placement, we will not have obviously any more recession, and that would be the second solution. The third solution, and probably the smartest solution, is we will do socket grafting after the teeth extraction in this thin biotype patient, and we will wait, and we will decide in 4 to 5 months if we're going to proceed with implant treatment, or if probably the best for this patient is to go with conventional implant prosthesis, because after all, implant dentistry is not for all patients. There will be some scenarios where it's extremely difficult to produce perfect or close to ideal results, and if the patient is very picky and thin biotype and high smile lip line in the maxilla, and etc., then obviously he would be presenting in that case too many risk factors, and when you have too many risk factors, that's definitely a contraindication. One risk factor usually not contraindication, but multiple risk factors might definitely present contraindication. So we will do bone graft, and we will wait and decide. Now the last class, class 3D, is also severe scalloping, but not normal. So we have the mild, moderate, severe scalloping that could be normal after extraction. But then you might have very super scalloping, if you will, but that's due to trauma or chronic infection. This patient was in a fight in a bar. He ended up in a coma for 3 months. The oral surgeon in the hospital connected those two teeth. He was referred to me for implant placement. So we did cleaning, and then you can see here I opened flap after removing all the granulation tissues and all that stuff. You can see we have scalloping quite a bit, excessive, but that's not normal scalloping. You know, that's due to chronic infection for a long time, few months, and we have quite a bit bone loss. However, what do you do about this? I mean, you can obviously do bone graft, the membrane, suture, and wait for a few months. And however, in this case, we don't have thin biotype. We have major scalloping, but not thin biotype. The bone and the bone architecture, quality, and then the soft tissue is definitely thick biotype. So although I have that much bone loss, however, I felt comfortable placing the implants. In this case, I went ahead and placed the implants, ignoring where the bone is on the buccal. I placed the implant ideally depth-wise, which is in the aesthetic zone roughly 3 millimeters under the highest bony level. And you can see, all the infection was chronic infectious. Tissues were removed. You have all those fresh bleeding coming into the side. And then I would place a combination of bio-os and any allograft, 50-50, to get advantage, to take advantage of both osteoinductive and osteoconductive properties of these two materials. 2 layers of bio-guide membrane, and then release the flap and suture under no tension. And this is 2 weeks later, suture removal visit. Now, when it comes to implant placement immediately after extraction, there is almost only two scenarios where I would avoid that. If I have acute infection, or I don't have enough bone to place the implant where I want it from the prosthetic point of view, and or not able to have the minimum torque, initial torque that I would like to have. So other than that, almost always I place the implant, and without bone grafting, depends on the scenario. This patient was temporized with the Maryland bridge and sent back to his referring dentist. So this will summarize class 3D. We have extensive scalloping, but that's not normal due to infection or trauma. I would either, on the lower left-hand side, you'll see you put bone graft membrane, and you will wait few months, anywhere from 5 to 9 months, and then decide. Depends on the amount of bone graft was placed. Not the material side will replace the implant and bone graft and membrane, and that depends on your comfort level. And okay, so now we can see here in these illustrations, that's class 3D summary. You have a bone loss, or you have scalloping rather, but not normal. We have too much scalloping. It's not mild, not moderate, not severe. It is, due to chronic infection or trauma. In that case, you will either do bone graft and membrane, like the lower left-hand side illustration, or you will be placing implant and bone graft and membrane. That will depend, of course, at your on your comfort level and the amount of bone and the biotype of the patient, aesthetic, non-aesthetic zone, etc. All right, so overall we have 9 clinical scenarios that we covered, and what to do per scenario regarding the implant depth. But in conclusion, regarding the implant depth, I would like to say one thing, that the ultimate reference you're looking at when you're placing the implant is the soft tissue level. You are in non-aesthetic zone. You need to have a good 2 full millimeter of soft tissue coverage above the implant's platform. You are in the aesthetic zone. It would have to be anywhere from 2.5 to 3.5. So in literature, you can see 3 to 4. I think 4 is overkill. If it's soft tissue, the soft tissue has thin biotype, maybe 3, just over 3. If it is thick biotype, maybe just over 2. So let's say 2.5 to 3.5. That's what I've been doing for many, many years with good success, and for the non-aesthetic zone, a good 2 millimeters, because you look at the initial stability and the implant diameter and all that stuff. That is nice, but for the longevity of the implants, the soft tissue seal above it is extremely important. We need to maintain no less than 2 millimeters in aesthetic zone, again up to 3 or slightly over. In order not only to end up with good aesthetic result, but for the overall health of the peri-implant soft tissue, the amount of soft tissue seal above it is extremely important. You put the implant a little bit too deep, you should either remove it, or if you're still comfortable with it, you don't think it's crazy deep, then you should restore it with screw retain, because it would be maybe impossible to remove the cement completely if the implant over 3 millimeter deep, relative to the level of the soft tissue. Other than that, when you have the ideal positioning, it doesn't matter really, cement retained, screw retained, as long as you clean the cement very well and you verify that with the X-ray after the removal of the cement, etc. So again, there's too many variables on deciding how deep should I place my implant, but the 3 in yellow in this slide are the ones I took in consideration when I put my classification. You do not want to place the implant too deep, because we have too many things, like bone loss around the implant that might occur after, immediately or after a small period of time, increased crown height, increased occlusal forces, increased sulcus depth, compromised aesthetics, difficulties with installment, cement left in the sulcus problem, etc. And this table here and this table here would summarize, if you will, this presentation. I enjoyed my time covering these two topics with you today. I would like also to, one more time, to tell you about my institute, California Implant Institute in San Diego, where we provide all kinds of courses from intro level to advanced, hands-on hard and soft tissue grafting programs to live patient program. Again, in our both locations, San Diego and in Rosarito, Mexico. As you can see, these photos here, our Mexico location, where doctors are guaranteed to place, 10 to 12 implants in a very nice setting, using very nice equipment, materials, state-of-the-art facility, and curriculum. This is my personal email. If you have any questions regarding the topic covered in this webinar, please feel free to email me. Would like to thank again OsseoNews.com for this opportunity, and thank you very much.